can I invite Mr. Suhail Chughtai for the next lecture? He's, everybody knows him. He has been the chief executive for organizing this conference for APPS UK. He's a consultant orthopedic surgeon and locum medical legal examiner, and he's Microsoft certified specialist. So he can be classified as a millennial, millennial senior consultant. That's a new logo I'm giving to him. And he's director of Medical City Online. So he'll be talking about virtual healthcare services, ensuring patient safety and quality of care, method and principles. Thank you.
Thank you very much, and it's been a brilliant experience for me to set up this conference and making sure that the topics are very powerful, and I think the galaxy of topics we had so far has been really the whole idea of the conference. I've spent about 20 years of my life in medical IT and about 30 years in medicine in the field of orthopedics. So I stand between the two. I stand where I prevent loss in the translation. That is where I stand. That when, as a doctor, you try and create an app, everything is lost by the time it's made, except a very small part of it. That is what I prevent. I create apps myself, I create programs myself in HTML and give it to my team of developers in my company who convert them into the modern language of MVC5 HTML. So I try to prevent that translation loss. My vision, in line with the improving the quality of healthcare and also enhancing the safety of patient on telemedicine, this is what my talk is about. And I want to show you some clinical adaptation of the digital services I've created, keeping the quality and ensuring the safety. So I have been very passionate about creating a medical city, which means that a place where all the healthcare possible on internet can be achieved in one point. So you go to a website and that has consultations, that has medical training, that has medical meetings, that can also help you to do specific fields like teleradiology, telepathology, teleretinopathy, teleretinography, and all these teleaudiometry as you go down the line. This is my vision, this is what I'm trying to work, and I've partly achieved that. So I just want to share some aspects of that today, just to show you the window where the light is plenty out there. So let's take a look. Medical webinars. How many of you are trainers who teach? I think all hands should go up. Now, coming to this conference would have taken you a lot of time from your hospital, from your traveling time. How if we do this conference on the web next year? But you can say the effectivity will be lost. Well, this is what I want to prevent. I want to do this conference next year from the APPS platform on internet with the same effectivity, but you can say that how can the guests be involved? Like you're sitting there, you can raise hand and you can question. But we will try to do that in a different way. That all you people here, from your homes, you can be simply dragged into the live room from your webcam. It has not happened before, but we are able to do so now in this technology. And in the next web conference we'll do, you will be able to ask questions in live video from wherever you're sitting by the presenter's discretion. He can just drag your icon wherever you are, as long as you've registered on the conference, into the live video room. Everybody can hear you, you can talk to speaker, and you can leave notes and comments. So let me show you how this is possible. First of all, the presentation, many times you're confused that how do I present? What should my presentation look like on internet? I had the same problem. And today, I'm not presenting any products, I'm presenting solutions. Because I had similar problems what you have now. When you make a presentation or webinar, you're struggling to make a template. So I created templates, 17 of them, which has different areas, like a presentation, slide big, camera big, slide small, multiple presenters, multiple slides, multiple videos. all these elements I took, put them in different combinations, and set them in templates. So you can pick and choose a template, that's your webinar. For example, this one. This is a template which is just a live relay, no PowerPoint. But look at this. This is a presenter here and a slide here. Then you have multiple presenters simultaneously, one in America, one in Britain, one in Pakistan, a classroom in Pakistan who are listening to you, and a slide in the middle. This could be a desktop sharing screen. So these are all created, which means that you don't have to worry. Just click and go, literally. Click and go. Because I had problems, similar problems. I thought if I have problems, my colleagues will have the same problems. So I could relate to what you're doing at laptop. But the advantage I had was I could create it. And that is the advantage I've used by doing this and hopefully serving my profession in some way. That's again a multiple presenters, and that's a screen shared by the top one. And then sometimes you just want a talk show, like you are here and you want to call somebody in America to take comments. So all these templates, like a multi-panel conference, you can have speakers just engaging in a dialogue. No slides. Like a question and answer session just like now. So these things are already there. You just have to log in and start doing it. This was what I was mentioning about, that you can drag a person asking questions. So this guy pressed a button called raise hand, like you raised hands. You raise hand, like this one. Dr. Altaf Rahman said that as he does that, he can just click a button on the internet screen below the presenter, and this will come up. It'll ask you, where are you from, what's your email address, and type your question here. You say, no, I want to come into the presentation room. I want to talk to someone. I can be heard. So you can send the request, ask to be a live video guest. Now, as long as your information is accepted by the presenter, all he has to do is just press the accept button, like this, accept video caller. This is a presenter's room, digital room of presenter. He has to just press this and you're in. Now, this technology is different. It's not the normal technology we've used here. I have micro-packeted the video bandwidth to squeeze through a small area and then expand it like Netflix, which allows you to have 720p high definition on a megabyte upload of half a megabyte in Pakistan. We're doing it in Pakistan. We are doing it in Pakistan right now. You will hear from the next presenter as well. This is happening in Pakistan. We are dragging presenters into conversations only using half a megabyte upload because of micro packet technology, which is a little patent I created. So this is a little introduction of what is medical webinar, what I'm going to try and do and introduce you to later. Yeah. So I think this is another area where probably we're very excited to do consultations on internet. All of us are. How can we do internet-based teleconsultations? A lot of considerations, a lot of options, but I think the options, if you go through all of them, they have a similarity. They are video conferencing based. They are not patient-centric. We want to create something which is patient-centric, and video conferencing is part of it. Video conferencing is part of the software, not the whole patient EMR is part of the video conferencing. And that is where the difference is. So I try to generate something. Now, why do we need telemedicine? We just want to do clinical assessment. We want to do therapeutic intervention, like suggesting some guy to have a mole excised because he's got streaks. Or we want to follow up an already seen patient in the clinic. We just don't want to drag him down from Kharia to Rawalpindi. We want to examine a post-operative case. Then we have non-acute medication review, like simple hypoglycemics or simple beta blockers you want to review on the internet. You don't have to call the patient from a different city to your clinic. Pain clinic management, another area where you have a lot of scope in telemedicine. Pain clinic medication after the first consultation can be reviewed on telemedicine because all that needs is a good quality video interview. So this is already not new. I mean, in Australia and New Zealand, they tried this experiment and they felt that the number of teleconsultations were increasing because patients liked it. patients felt, well, I don't have to go to the doctor. I can talk to the doctor in confidence. He can see me, I can see him. As long as the user experience is good, this is acceptable. Plus, the tools are there to engage the patient. I'm going to show you those tools in a moment. In Al Khan University, we've got Professor Atar Inam, Professor Dr. Munir Ramanullah here. They are doing a lot of telemedicine in Pakistan. In fact, the most telemedicine activity is happening in Pakistan is at AKU. Now, this is their paper. They went down to villages in Gilgit or remote areas, Chitral and Gilgit, and they did the remote telemedicine just for the primary care. That experiment did help them to understand what are the barriers, and that is even important. Even if you can't deliver it properly, if you understand what are the barriers, you can deliver next time better. So this is what happened to me in Pakistan. 2 years ago, I went to Pakistan, I wanted telemedicine. They said, look, these are the barriers. I said, okay, how much time? They said 2 years. I said, we haven't got time. We have to find ways to go through the barriers. And that is where I mentioned the micro-packet technology, that we fragment the bandwidth, video bandwidth, get it micro-packeted through the narrow bandwidth, and reassemble it, like Netflix. So Netflix is on telephone lines, but you see DVD quality videos. I have a similar adaptation of that in my technology. So what are the benefits? Time saving, of course, travel time, waiting time. I was in CMH Lahore a month ago. The last token in OPD was 309. 309 patients in one day. They have capacity issue, they have volume issue. I said, well, look, give me a small room here. I'll set a telemedicine here, and that guy will triage the patients from different cities. You get X-ray done, you get these blood tests done, and then come. And we expect 1/3 of the patient's number to be dropped by that. And that is what we're doing in Pakistan now. I'm being called again, and which I'll be going very shortly, to discuss how we can solve the volume capacity issues. The CM of Punjab was here, and we discussed that option, and it's going to happen very soon. Cost saving, of course. Patients who come, they don't come alone. They have their uncle, they have their brother, they have their sister, and the hospital has to pay for them. By the way, there's a project called RAHA, R-A-H-A-H. I recently installed in Saudi Arabia. I connected Riyadh Central Hospital, King Saud University, with 5 different cities. And that hospital service has 65,000 employees. So they don't come to Riyadh now. You know, Saudi Arabia is huge. You know that. It's a huge country. So now they don't come. They do the first triage on digital medicine. Not acute, the chronic problems. And then that has saved the hospital already approximately 1/3 of their payment cost to the patients. So this is a business model, not just a clinical model. It can save cost, it can save time. Patient privacy, this is what we discussed. Anna was saying, Anna Roland, that GMC is looking at it, but in Pakistan at the moment, we have our own means, like HTTPS. My websites for this are all SSL certified. Then we have triple level encryption within them. Even I cannot access patients' records. Being the creator of the software, I cannot go into patient's folder. Because once if the patient allows me, only then I can go. So, a lot of benefits. I just want to share this slide with you, very important one. What is the principle of telemedicine? Like in clinic, you got patient sitting in front of you. All you need is a good interview. Talk to the patient. Okay, this can be done on video conferencing. You need to scroll the medical records. This can be done on video on the EMR system. But the gap is the physical examination, and you have to replace that with a visual examination. So you have to replace it with a visual examination. Now, what we do is, external rotation of shoulder is this. You tell the patient to do that. So maneuverize the whole thing in visual format. The word is, you have to learn to maneuverize your clinical methods into visual shape. And in many specialties, we can do that. In orthopedics, I know I can do it. It's possible. In many other specialties, it's possible. I'm writing a book on that. I have been in touch with many of my colleagues who are helping me in their own specialties. So let me show you the software now in 2 minutes. So the patients register, just like a form. That's the doctor form. They will log on, and they will go to a screen. In that screen, this doctor has got appointments. For a new doctor, there won't be any appointments. So doctor can fill up the CV here. And then doctor can create a clinic. You can see that red button there. these are all the menu options. He's on My Clinic. He can choose what date, the time from and to, one off or every week, alternate week, and then how many minutes a slot. And the title of the clinic, knee clinic, back pain clinic, gynecology clinic, and then the number of sessions per, or you can put the fee here as well. And then he can choose the medications I have put in the software, about 1,000 of them, or he can create his own medications by the plus button. Then diagnosis, I have around 700 conditions here. Or he can choose his own conditions. Again, these are the investigations here, or choose your own. So this way he can set up his clinic. Now this is again a very important part where you put up anatomical illustrations, like shoulder pictures. So you tell the patient what is wrong with the shoulder with the help of a picture in front of you. He's seeing the picture, you're seeing the picture, you're drawing on it. That's wrong with your shoulder. Same way the patient fills up the form. Now the patient searches for a doctor on the system, and then he looks at the CV of the doctor, and then he says, look, he's got appointments. He can fix one appointment, just click here, and the system will navigate you through appointments. And then he can upload the medical records. Just 5 seconds on this one. If you have got a capability of attaching an email, a file on an email, as a patient, you can do this model. If you can attach a file on email, a patient has the capability to use this model. And that is what we tested. We had about 20 people of different intellects, and 3 of them did not use could not know how to attach a file. The rest of them did. All the 17 were able to understand this in 30 minutes. The ones who did not attach a file before, they could not understand this software. They had to be taught. And then you can just choose the medical records. I just want to show you one screen here. Yeah, so this is the patient side. The patient is on the top, and the doctor is here. And this is the doctor's side. The patient is in the middle, the doctor is here. Now, this is important. What doctor sees on the screen, the patient is looking at the same screen, and that is the main thing. So that means the patient is not blinking eye. You're not blinking eye. You're engaged. What happens in clinics? You got notes here in the lap, and the patient doesn't know what you're looking at. This is engaging patient, because he can stop. Doctor, stop, stop. I can see some wrong numbers here. Can you tell me about that? And the doctor will mark, and the patient is involved now. Patient is not sitting like aloof in the corner of the clinic, and you're scrolling through the pages. No more. This is what I propose. Like this, he can stop you here, and doctor can draw on the screen. Even you can share the X-ray like this. You can draw on the screen and mark that what is wrong with you is here. You can share the videos, and then you can go through the navigation part where you can choose a medication. And while you're choosing a medication, you're telling the patient at the same time, all of that. And that is where you educate the patient. Just with your permission, 30 seconds more.
You got one life left.
So I want to show you the live tele-supervision part. This is my favorite bit as a surgeon. This is important because a surgeon operating in a different theater, in a different city, in a different country, is watched right here on your mobile phone. And you can tell him, guy, you're going too fast, slow down. He's your registrar, he's operating somewhere, and you're watching him because his screen is connected, his arthroscopy screen, his angioplasty screen is connected through a special bandwidth on your mobile phone. And then you freeze the screen and draw it back to him. That is not what you do. You do this. That is the meniscus. That is the blood vessel which is narrowed. Cut that or do that, like this. This is angioplasty happening in NICVD, National Institute of Cardiovascular Disease, Karachi. They are using this software now. And the surgeon is here, angioplasty surgeon. This is another surgeon in another country. He is watching this procedure live on his mobile phone. And the classroom in Aga Khan University somewhere else is watching that whole procedure. They are talking to each other. Then he notices something wrong. He will quickly mark it. And that mark will appear on the other surgeon's screen who is operating. And he will say, look, guy, you got to avoid that. You got to minimize the size of catheter. It's too wide catheter to go through that. And this is what we have achieved. And I believe virtual healthcare is not the future. It is the present. I don't think we are talking of future. What I've just discussed with you is not fancy. Believe me, it's necessity. We are doing it. in Pakistan, in Britain, we are far ahead from Pakistan in technology. If we can do in Pakistan, we can do in many, many other countries in the world. Thank you very much.
Thank you very much, Suhail. There are a lot of questions. I think they won't be.
I'll just take one question.
All right, okay. Authorized himself, so okay.
So thank you much for a very good presentation and your innovation. But being a urologist, I have difficulty to examine the patient.
Yeah, okay, this is what we're discussing. You know, actually a very, very important point. I just want to address this point. In UK, as an orthopedic surgeon, if I examine knee, I've got a perfect interior draw, which means the knee is floating. Rupture of ACL. Right, sir? Everybody understands? Rupture of ACL?
Yeah.
Answer one question, please. Can I go and operate on this patient without MRI scan? Those who think I can, please raise hands. I'm very clear this guy has got ACL rupture. I'm going to take him to theater. Can I do that without MRI scan?
No.
Yes.
Who says yes? Have a good insurance policy.
Yeah, you shouldn't.
With your experience, you can.
No.
Please, can you answer this question, Usman Saab?
No, you shouldn't. You got to have an MRI. Although I'm not an orthopedic surgeon, but at least I know that you got to have an MRI. You can't take a patient to theater.
Anybody
On
else
a
agreeing with
clinical
that quick question?
diagnosis in orthopedics.
Hell, that's not the point. The point
Just
is,
examination.
And I'm coming to that point. I'm going to address that.
this way you will be MRI every.
No. I'm coming to that point. I just want to emphasize this first, then I'll address the question. Now, that means that in visual examination, there will be gaps. Those gaps are filled by investigations. That's what I'm trying to get at. I'm not saying that you make a critical decision on the basis of telemedicine. What I'm saying is you get more information. You know that you realize the gap. There should be a bell ringing there. I cannot make a decision on the visual examination in this particular area. I need investigation.
You need to see the patient because
Not every patient. Not every patient. In melanoma in Glasgow, we picked up a patient just last week. I was saying to Bilal last night. We picked up a patient on the basis of streaks. We did en bloc. It was a melanocarcinoma on the basis of telemedicine. Did not examine the patient.
an MRI won't tell me whether a prostate feels malignant or not. Finger will. MRI.
But will you do MRI before this arthroscopy?
Can I suggest that we will
Can I say something, please, before you finish? Excellent presentation.
Thank you.
In fact, we have recently started visual clinic in our fracture clinics, actually, exactly what you are suggesting, because once patient has been seen in outpatient, doesn't need to come back. You are absolutely right. Second thing is, what worries me is that if next year you are going to have this conference on
Internet,
the basis what you are saying, teleconference, that really is very disappointing for me, because I have met friends over here which I haven't met for 35, 36 years.
You look
You
at
know,
the social part of it.
that
Okay.
physical contact which I've
Okay.
had is just
I'm warned. Thank you.
unbelievable.
Thank you.
And I don't want to lose
Okay,
that,
that's fine.
please.
The last point, Charles said one thing. Charles had a very good point, disruptive innovation. If I'm making you angry, I'm really happy. I'm really happy because I want this feeling that I'm doing something which is not thought of yet. And believe me, next year, you might be able to agree with me. Thank you.